Well, it's really good to be here, and I'm happy to be asked to do some presenting on the need for more simulation. I think that many of you are probably in some form of wonder about how we're going to navigate this. Is it ever going to end? And how is this going to affect me? How am I going to keep my simulation work going? And what can we do in the meantime? And I have a bunch of ideas on a lot of that I'd be willing to share. Tom asked me to basically title this The Need for Simulation More Than Ever. I think probably because he's getting tired of hearing me talking about it, honestly. So I'll just start with, I know it's not a CME event, but just for good ethics disclosures, I don't really have anything pertinent to this topic that's direct. I do some personal consulting on the side along with stuff that we do with Wiser. The opinions that I'm going to share are mine. They don't represent UPMC. They don't represent the University of Pittsburgh or Wiser. So if I say anything that really strikes a chord with you, take it up with me and we'll be happy to chat and debate. For those of you not in the area, Pittsburgh's a beautiful place. We would welcome you to come and visit whenever that will allow. I recommend that you visit in the next week or two or wait a few months. Otherwise, when you get here, this is kind of what it looks like for most of the winter. I thought that I would, Tom asked me to talk for about 30 minutes and leave time for discussion. And I structured it sort of just a little bit of a brief background of overview of Wiser and UPMC. And I'm not making this a Wiser infomercial by any stretch of the imagination. I just think it's important for people that are not familiar with Wiser to understand sort of our approach to simulation, and it might give some insight into the way we make our decisions and thoughts. Talk about challenges and opportunities specific to COVID, and talk about the value of simulation, quality improvement in patient safety programs, and then how we're going to advance for the future. And I really believe the future is now, and if we don't plan for it, it'll be right on top of us. And we really need to think about it and get rolling with the future of simulation now and not wait for a complete COVID mitigation strategy. I'm a practicing emergency physician. I still practice regularly. That's a question I get asked a lot. I've been the director of Wiser for a long, long time. I'm the medical director of patient safety for the UPMC health system, which at present has 40 acute care and specialty hospitals, mostly concentrated in southwestern Pennsylvania, but we span to the middle of the state and into a little bit into Maryland and one up in New York. Wiser is dually affiliated with both the university and the UPMC. On the university side, we deal with probably what you deal with on your school side: schools of nursing, schools of medicine, school of pharmacy, and our preliminary affiliation there are our schools and our students of health sciences as well as research endeavors. On the UPMC side, it's the classic behemoth big hospital system. We are responsible or contribute to supporting the hospital efforts, patient safety efforts, staff and provider training, professional education and residency education, all at as it involves simulation or innovative learning. And those I always referred to as our parents, mostly a non-dysfunctional relationship, but we have advantages for having two different parents from time to time, but it does stretch us a little thin operationally, but it makes the mission much more exciting. So Wiser, just the quick skinny on Wiser, we have a main campus, if you will, that's about 16,000 square feet or 1,600 square meters. It's kind of right in the academic hub of Pittsburgh. And over the years, we have built out 8 satellite simulation centers of Wiser just in southwestern Pennsylvania in our member hospitals. We are accredited by the Society and the American Society of Anesthesiology, and I'm proud to say we recently became accredited in fellowship programs. As you probably know, it's a new domain of accreditation offered by the SSH, and we just achieved that. So we're proud of that as a team. We're a busy center like many of you. I won't bore you with those details. We're multidisciplinary. We see students, we see practicing professionals, and everybody in between. These numbers reflect our main campus numbers, not our satellite center numbers. So digging in. Things have changed. No doubt about that. COVID has changed many things. In lots of it on the practicing end or the healthcare delivery side, but a lot on the education side that I'll focus on in a little while. Pressure on the healthcare system to produce, and it's creating pressures. One of my colleagues has said this the other day, that one of the things that COVID is doing to our healthcare system is not necessarily creating new problems, but exposing vulnerabilities and amplifying existing problems that weren't such big problems previously. And I thought about that for a couple of days, and I couldn't really push back at the time because it was one of my bosses actually. But then I thought, wow, that's really insightful and really resonates with a lot of what goes on around our system. Changing in the providing of care, whether we're talking about PPE, whether we're talking about how social distancing affects care, affects employee workflow, care provider workflow, patients, visitors, etc. Big changes in education, and I'll separate the words for the purposes of this talk between education and training. Education meaning that ongoing long thing that leads towards licensure or certification, and then training, everything thereafter. That's a simple way of differentiating the two. We are actively engaged in stopping the spread of COVID, although at the moment, if you watch the news and look at the numbers, it does feel like a losing battle. I think we're in the amidst approaching a storm of a second wave, it's fair to say. It's changed dramatically our social interactions, both at work, both at home, and altered a lot of training plans. Training is one of those things that I think of as what we need to do to have practicing professionals ready to go to touch a patient. You know, education is building up that knowledge. The training part is go time, that dynamic has been changed considerably in some places, and we're going to talk more about that. And then lots of fears in the staff. And the staff fear is an interesting one insofar as it doesn't always manifest itself as I'm afraid of COVID. Sometimes it's just maladaptive behavior. Sometimes it's passive-aggressive behavior. Sometimes it's aggressive behavior. There's lots of challenges with dealing with staff. And when I say staff, I'm talking about everybody on the healthcare team, not any one entity or any one silo. And I think as leaders and managers, it's really important to remember that this exists. Even in your most resilient, your most hardy employee, that nothing's bothering them, there is a possibility that there's some deep-seated fear about the disease, or I think more commonly is the effect of the disease on us socially, economically, emotionally, and in hampering our ability to provide the care for patients that we want to care. And that goes into the fear cycle as well. So what's not changed? I want to challenge you with that. What has not changed is patients getting high quality care. The need for that actually, I would say, is even up. You may have heard the emergency department numbers are down and on and on and on and on. And it's largely true in most of the country, but the need for care hasn't changed. And whether a lot of that care is shifting to telemedicine, inpatient care continues, and as this wave of COVID increases, that becomes more pressure-filled, and there are more people in the hospital with needs to be cared for like never before. And in this new care environment with PPE, social distancing, not having, let's say, family members or support members at the bedside to help, the onus has fallen upon the care team to really ramp up. And we're talking about a stretched-thin care team before COVID. The bean counters were going around eliminating heads because they thought that the job was too easy before COVID. Now, during COVID, the job has gotten harder. No new providers are on deck. the pressure that it takes to care for patients is higher than ever. So that has not changed or significantly been amplified or increased. Patients require safe care. Okay, that hasn't changed. The need for essential training has not changed. Okay, one of the things that I hope that you come away from this talk, or at least a half a dozen of you coming away from this talk, embrace the idea that simulation is a core part of healthcare delivery. It's not a bolt-on. It's not additional training that's nice to have in a fancy center with cool things. It has been integrated as a mechanism that is just like any other piston in an engine, a integrated part of the healthcare delivery. Patients count on it. It's not optional. It's not something that we could just shut the doors and say, yeah, well, we'll just come back when this is all over. Okay? Nobody wants to do that. But part of it is a leadership mindset of understanding that simulation is now more important than ever, and I'm going to make that argument here in a few minutes, but it has been, over the last 20 to 25 years, we have integrated it into the delivery of healthcare. All right? And now we are also needing to educate new providers, because another thing that we have seen is a significant exodus of people leaving the healthcare workforce for lots of good reasons. COVID has again amplified that, and we are now counting on new grads to quickly transition to practicing professionals and take care of patients earlier than they ever would have done independently previously. So this need for education to continue is important. And some argue when I talk about the difference between training and education is, yes, we should continue the training. We should continue the central line efforts. We should continue the airway management efforts because that directly affects patient care. Well, I can tell you from an epidemiologic or population perspective, new healthcare providers entering the workforce is an epidemiologic pinch point. We really need to keep the flow going. Okay. And then the other thing that we need to do is make sure those people that are graduating from schools of nursing, schools of medicine, and schools of pharmacy are just as well trained, if not better, than they were before the COVID era. Okay, this is a critical thing to think about. I recently said at a staff meeting at Weiser, I said, let me put this in perspective for you. If you get sick next fall and you enter the hospital, everybody jokes about July and the interns and all this other kind of stuff. You get sick and go in the hospital next fall. If we don't continue high quality education and transitional training of healthcare providers, the intern that takes care of you will not have seen patients directly for over a year, year and a half. The new grad nurse that's on the floor taking care of you or your family member will not have seen a patient live and touched a patient live for a year or a year and a half. Okay? If that doesn't kind of remind you or stimulate you as a leader in simulation, think about that thought, and that should be part of your capitalization and planning efforts for moving forward during the pandemic. So I want to take a few minutes to just share a few ideas and thoughts. And I'm not trying to say this is the pathway. I'm not trying to say that this, look what Weiser did, as much as just share in the creativity of how we created value during the crisis. So one of the things that I think is really important to think about is this, figuring out what must be done. The first thing that has to be done is take care of the staff. All right. So I'm talking about, how does the simulation center engage? This could also be something to do with hospital leadership too, but we're talking about simulation programs at the moment. We must take care of the staff. Okay. We need the staff to know that we are looking out for them. We need to know that we're making decisions on their best interests, and we need them to know that their role is essential in the care of every single person that is seeking care from the healthcare system globally, but we'll focus this discussion on the United States. So take care of the staff in lots of different ways. Reassure them. Make sure that you're as transparent as you can be with the information. Okay, when you need to step back and regroup and change policies and change procedures, do it. But take that pause with the idea that we need to get back to work because we are essential to the care of patients. All right. Priorities change. Look for opportunities. What was the priority in January or February is a whole lot of different for simulation leaders now than it was perhaps a week or two ago. So figure out what needs to be done and figure out where those opportunities come from. Sometimes they come from the strangest places. This is a picture of us doing calibrated smoke testing at Weiser a few months ago. And everybody was trying to build their own version of the box. Many of you saw the plexiglass box with the 2 armholes for the intubation and so on. And it turns out those plexiglass boxes with the 2 armholes didn't do a whole lot except make intubation more difficult. Well, we had an ingenious plastic surgery fellow, actually, that came up with a different idea, different engineering approach to the plexiglass box. And actually what he ended up creating was these negative pressure biocontainment units for a patient. For one patient, where airway procedures could be carried out unhampered by the holes in the plexiglass box, and the patient could get safe airway care, whatever that is, intubation, BiPAP, CPAP, etc., and keep the environment and the staff safe. And we were a testing laboratory, and what's being done in this picture is calibrated particles of 0.3 micron smoke that could be counted by machines were injected into this hood while airway procedures were going on, and the environment and the amount of escape from that calibrated smoke of 0.3 microns, incidentally the same size as the coronavirus, were counted and figuring out if this thing was going to work or not. And now there's patents that have been pended, there's emergency use authorization going through by the FDA, and so on. We were a key part of this from a testing and research perspective. Redefining airway. My team from the emergency medicine department at the University of Pittsburgh recently published a paper in the Western Journal of Emergency Medicine, and it is how we took simulation into the front line of the hospital. This was months ago at the very, very beginning, and we re-engineered how to do airway. And you might say, yeah, big deal. This is a simulation talk, not an airway talk. Well, the cool thing is we use simulation in 2 forms for this, and I talk a little bit about it in the paper, and that is we use it as a training tool to deploy our new airway algorithm and our new approach and process to airway. But more excitedly for me is we used it as a measurement tool, and we did iterative revisions in rapid cycle deliberate design practice to be able to design this new airway algorithm, test it, and then as we built it, we were teaching and deploying the wares of this investigation period across the system so that we were able to be ready when the first flood of COVID patients came to our emergency departments and critical care units. So it was a cool thing. So we're using simulation both as a training tool, which is very, very familiar to all of us, but also as an iterative development tool to make sure that we get things right. We figured out, what worked and what didn't work, because, every new idea sounds great until you put it to work, and then you have to start refining it. And we use simulation in both of those capacities. So we, and I know many of you have done this, I'm just trying to outline this for the whole community, but we also did a lot of work with our member hospitals in their readiness to don and doff PPE safely, how to process big procedures, patient movements, et cetera, and we did lots of planned in situ evaluations and some unplanned in situ evaluations to help our member hospitals that requested our services to know where to invest and know where to put their training efforts and time moving forward into the future. But I want to refer you back to a paper that I wrote with a big team of people back in Simulation in Healthcare in 2016. And this was around the Ebola treatment preparation phase. And Weiser led basically the development of the Ebola response teams and certification for the whole UPMC system. And it's kind of odd, you'd think, that Weiser led it. The Simulation Center led this. And what I talk about in this paper, and I think only 10 people have ever read this paper because we put it in the Infectious Disease Journal under Ebola readiness. I really feel like I should rewrite it and put it into a systems-based paper so more people would read it. Especially now that Ebola is not a thing anymore. But I talk about the value of pre-existing relationships inside the hospitals, inside your health systems that allowed this to be the case. And they knew that Weiser was the go-to arm to do a lot of testing, to do a lot of rapid cycle training development, and to be able to do assessment and carry out the plan. And without pre-existing relationships or inserting ourselves into the delivery of healthcare across our system, this would have never happened. And I would encourage you guys to read this paper if you're interested in thinking about ideas of how to integrate and penetrate further into the different systems of complex organizations. I like to say simulation programs need to be hardwired into the healthcare system to function at maximum effectiveness for patient safety. So you see here's a circuit brick for nursing, here's a circuit brick for finance, here's one for risk management, here's one for the laboratory, here's simulation. It looks like all the rest. It is hardwired right into the circuitry of the hospital. It's not a bolt-on afterthought, okay? It's not this old piece of luggage on this car that looks like it got tossed on at the last minute to go on the trip. We want to put simulation right here in every hospital in this country, not for our own good and our own careers, but because we know it makes for a better care environment for patients. It makes for a better work environment for healthcare practitioners and providers and everybody that's involved within one arm's length of caring for patients. I talk a little bit more about that in a recent editorial that some of you may have seen in Simulation in Healthcare. That was in August of 2018, Simulation Integration in Patient Safety Systems. And in there, I discussed that partnering with quality and safety experts of the affiliated systems will catalyze deeper involvement with and shared learning with respect to existing problems and simulation opportunities. Because I'm not going to go into this right now, but suffice it to say, without this relationship, without the pre-existing understanding of what simulation is capable of and what it is not, it's hard for hospital leaders to turn to you as part of the solution. So when you're fully integrated and share a deep relationship with the leaderships inside the hospital, risk management, quality, safety, etc., then you can educate them over time. Nobody's going to watch our Welcome to Simulation video. No executive is. They're not going to attend Simulation 101. They're not going to even listen to a 15-minute lecture on the benefits of simulation. They count on you as a leader and your involvement at the table to educate and let people learn what simulation can do for them and how do we solve the problems of the healthcare systems for the future. So this is challenging. Many of you have a simulation focus that's on one or two providers at a time. Some of you have, many of you have foci that involve teams of people. And then it's very common for people to do some training for individuals, some training for groups and teams. But what I'm suggesting is this whole deeper idea. We have to worry about the people, yes, but we also need to worry about the engines and the inner workings of the hospitals and the health system to be able to bring value to your system, bring solutions to the executives that are counting on you, and bring support down the road for your simulation sustainment program. And this isn't easy. This isn't easy to achieve. I kind of look at this as like a seesaw, and when you put more efforts into the system side of things, you kind of sacrifice on the people side of things, and when you put more efforts into the people side of things, you kind of sacrifice on the system side of things. So as a leader, it's up to you to position this fulcrum of this seesaw within your organization so that you can maximize the benefits of your simulation program and you can maximize the benefits of simulation to your patients. Okay? Because one of the other messages I'd like for you to get from this particular talk is to think this: the ultimate beneficiary of simulation are patients, not students of simulation, not the people that we're running through our scenarios. The ultimate beneficiaries are those that are cared for by the healthcare system. And if you shift your focus as a leader to think about that, I think that it will help you make better, more informed, and more purpose-driven decisions for the future. But think about this idea, and we only have so many eggs to put in each basket, but you need to bring the biggest bang for the buck for your patients and for your system. So what do? Protection. I already talked about this. We need to make sure that we have safe sim. And I think that many of us have been through that drill already, but we want to make staff safety, the faculty and student or participants of simulation safety paramount. Not only do you want to do it, but you want to talk about it. You want to make sure that everybody knows. You want to make sure that everybody knows that they are safe if they work for you. They are safe if they teach for you. They are safe when they come and learn from you and engage in the simulation programs that you offer. Okay? So tackle those things first. I think most of you have already done that. But I would say, please don't run and hide. Please don't shut your center until it all goes away, because there are so many patients that need your wares that are the product of all of your simulation efforts, whether you're on the training side, the investigation side, or the education side. And I'm going to keep talking a little bit more about that. So keep going with the safe sim, reevaluate the curriculum, okay? Figure out what is essential, what is non-essential simulation training. So I'm not arguing that we need to or we should be running all the training efforts that we were running before COVID. I showed you our numbers. We have a lot of training going on, okay? But there has to be some sort of prioritization system that says this is still core. If you ask me, anybody who's getting a central line put in, anybody that's going to the operating room, anybody that's getting put to sleep for anesthesia or in an emergency situation, all of those things immediately smack of there's a whole lot of essential training that needs to go on before that happens to those patients, okay? Then there's others that can be maybe perhaps a less priority. And then the other thing that's hard to do is take what you've been doing, some of you for many, many, many years, the same way over and over again, and say, can we change this? Can we change this? And maybe we're changing this in a way that is less ideal than you had hoped. But, in times like this, perfect's the enemy of good enough. But the other thing is, now that there's a lot more resources for online education insofar as technology and know-how, but also insofar as acceptance versus what do we need to keep as on-site simulation. Don't be the person that's driving the ship in the same direction because you've been driving it that way for the last 5 or 10 years. Be the person that says, how can we reevaluate to meet today's priorities, today's training requirements, dealing with today's crisis, okay? That's what you want to do, so then you'll make good decisions. Then once you figure out which of your curriculum is essential for your training efforts and which is essential for your educational efforts, then start re-engineering. Figure out from the simulation perspective, what are you going to change? How can we make smaller class sizes? All right, because we want our ongoing efforts, even during COVID, to align with what the general accepted principles are that keep us safe during COVID. All right, so we want to spread people out. Maybe, we have a lot of faculty members that like to teach their course in their very room at Weiser. And I'm sure all of you guys have the same kind of faculty member. And you know what? Maybe you just have to say to he or she, we're going to move you to a bigger room. I know it's not your favorite room, but we're going to do that so we can spread people out. So bigger training spaces. Our staff has spent hours and hours and hours working with our course directors and faculty to accommodate these things, shifting the schedule, adding more classes so each class can have less people, finding new rooms and new spaces to conduct the training in. So bigger training spaces, and then perhaps more frequent classes with less students. Sometimes that's a hard sell with some of your faculty, particularly if they're getting besieged with new clinical or additional clinical responsibilities. But again, as leaders, it's not up to us to make the easy decisions. It's not up for us to make the easy asks. We need to be pushing forward in a way that we know is bringing value to our organizations and subsequently raising the quality of care and the safety of care to patients. So I'll finish up with looking beyond the crisis, and maybe this from the crisis we're in now till moving forward, however you want to look at it. Besides the learning opportunities, bedside learning opportunities have been severely impacted, okay? And what used to be kind of almost observational learning at the bedside is now non-existent learning at the bedside or completely observational. I don't think that's going to go away anytime soon. There's a risk piece associated with it. There is a PPE consumption piece associated with it. There's the fear factor of the faculty members who need to support in hospital or I should say bedside training or clinical experiences. And those challenges are not going to go away. So I call upon us in the simulation community to really, you either develop yourself or meet with the appropriate faculty members with the subject matter expertise to think about how can simulation push forward to relieve this crisis of the future. Because again, it's not going away. And remember that story I told you about if you're in the hospital next fall, who's going to be coming to your bedside. So maybe what was thought as trivial or not necessary prior in the simulation world, now that the students are 2 or 3 arms lengths away from the patients or not even near the patients at all in some circumstances, what can we do as a simulation community to close that gap? Okay. Continue to think about simulation as an assessment tool. I gave you some ideas of how we probe our system, thinking about focusing on the individuals and teams, because we want to still, even in time of crisis, give feedback to our hospital leadership so they know what to prioritize, both their investment as well as the time involved in personnel training to move forward, so that they don't keep doing the things that they do well over and over and over again insofar as an investment perspective. Find the things that they need to shift to help them invest their money and their time of their personnel wisely. Think about that, taking the temperature of the hospital, identifying the problems, and feeding it back to the top floor or wherever the C-suite of your hospital lives. Ideally, we want to get into this situation where we are helping to prioritize the spending of our health system. Now I'm kind of speaking to the core of what we need to do is simulation leadership, but also it's with the good intentions of increasing and subsidizing our current amount of support that we get from hospitals and health systems for the benefit of patients in the future. So my little model here shows this hospital with the engine that I showed you previously, and there's lots and lots of money inside this bubble of the hospital. And there's lots of people competing for this money, as you might well expect. And if this is the pipeline of education and investment in training, so I'll say education training pipeline, some money will flow out of this hospital silo, if you will, through this pipeline and then come through these pipes in various forms. And they hit a valve. And those valves, as far as how much money is floating into these programs, and these programs were just like off-the-cuff programs. They're not necessarily in order of some kind of rank, or this is not a scientific project or review. This is just my idea of conceptualizing where we are and where we need to get to. And the people that have their hands on this money are the people that run training not related to simulation, but more importantly, they run the risk and the quality, and they have access to the risk and quality data that's in your hospital, because that's where the problems are. The problems are not within CPR training. The problems are much deeper than that. CPR is not even the tip of the iceberg. ACLS is not even the tip of the iceberg. What you need to do is befriend these people here in the risk and quality centers to get access to their data to find out where the true problems are. Because if you do that and establish those pre-existing relationships I was talking about before, then you, as the simulation program up here, or simulation leadership, you get a hand on that valve too, and you get to control some of the aspects of where that money is flowing once it enters into the education and training pipeline. So I said that I would only talk for half an hour. I'm a little bit over time. I apologize for that. But those of you that know me know that once I start talking about simulation, it's really hard to stop. I'd say that inside of challenges, there are opportunities, and that is a mantra for life. It certainly is applicable right now in hospital leadership and hospital operations. It certainly is, and probably always has been, an opportunity for us in the simulation world, at least in the 23 or 24 years that I've been involved in healthcare simulation. Again, I ask you to shift that thought process. Please, 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 patience. Patients need simulation training. Patients are the ultimate beneficiaries of our efforts, okay? When our efforts are directly involved at patient safety, it makes it an easier case to sell. This is to remind me, we just released our patient safety report that basically highlights the last 2 years of our efforts that have been dedicated almost solely to patient safety. And if you want a copy, get a hold of us, and we will get you one if you haven't received it yet. If nothing else, just for some ideas and some thoughts on how we prioritize ourselves inside of our system. So with that, I will end this talk, and I want to say I'm very grateful for Tom and the others that run this effort to invite me to talk. I look forward to, if there's some office chit chat afterwards. There's a whole lot of ways to get a hold of me and or Wiser. I run a group called Simulating Healthcare on Facebook. That's a good way to get a hold of me. And then on my blog at simulatinghealthcare.net and any of the Wiser contacts. So thanks again, and I look forward to seeing you in the future. I look forward to interacting with you again, many of you again in the future, when we can actually be together and shake hands. Thanks again.